Hi, good afternoon. My name is Christina Bauer and I'm with the Texas Lyme Alliance. And a friend of mine, Cosette Lake, and several others came to support Dr. Rajadas for his research in discovering disulfiram in treating Lyme disease patients. And I'm here today with Dr. Kinderlehrer. Before we interview Dr. Rajadas, who is a treating physician for Lyme disease and chronic illness, I imagine, as well.
My patient population is limited to people with Lyme disease complex.
Okay.
Yeah.
And he's currently in Colorado treating patients with disulfiram for Lyme disease. And I wanted to get his opinion on treating Lyme disease with disulfiram. We have a few important things to get to today. But first off, I wanted to say thank you for doing what you do, because it's definitely a labor of love. Most people I interview that treat Lyme disease do it because they have some kind of personal motive, and just wanted to say a big thank you from the Lyme community for doing what you do.
You're welcome.
So first off, when did you discover that disulfiram was effective to treating Lyme disease patients?
Earlier this year, 2019, Dr. Kinderlehrer was sharing his experience on the iLab's email listserv, and that's when I first became acquainted with it. I spent a long time talking with Dr. Lehrer on the phone, where he told me lots of details of his experience, and that's when I became interested.
Very nice. And how many patients do you currently have using disulfiram for Lyme disease?
At present, I have over 60 patients who are on disulfiram.
That's wonderful. So when did you start your first patient on disulfiram for Lyme?
First patients were started in March of this year.
March. And how are they doing so far? I know that's a broad question over 60 people. What do you think as far as side effects and the actual treatment protocol for patients? How has it been?
So, as you said, it's a broad question, so I'm going to narrow it down. Some of my patients have been on disulfiram much longer than others. Some have been started more recently.
Okay.
One thing we found right away, and Dr. Lehrer has as well, that starting at doses like 500 milligrams are way too high for any of my patients, certainly. We actually start patients at somewhere between 62.5 and 125 milligrams every third day. So the first hurdle to overcome is the Herxheimer reactions. And if we start slow, usually they're minimal, and we have ways to help people with Herxheimer reactions. An occasional person, I have a handful of people who've had to drop the dose even lower than that.
Okay.
The good news is that over time, people are able to progress the dose. So what I have my patients do is check in with me every 2 weeks. That is, we start them on a dose, and I ask them, in 2 weeks, email me. Tell me what happened, and what have you noticed in terms of Herx reactions, what have you noticed in terms of benefits, and give me an updated medication list. Because as we increase the dose of disulfiram, we are tapering their antimicrobials.
Okay, that was my next question. Thank you.
Of course, they know to stay away from alcohol products, and now we're finding about other products that contain acetaldehyde. We're certainly limiting yeast and treating yeast aggressively. And what we're determining in terms of dose progression is, are they tolerating the medication? Are they having Herx reactions? Or are they undertreated if we're taking away their other antimicrobials too quickly?
Okay. Did you have something else there? Because I have loads of questions.
Okay. So I can tell you that many patients are saying, I can't believe how good I feel.
Yes.
Quotes like, amazing, great, I forgot what it was like to feel so well. It's really has been a game changer. It's very, very clear that it's hitting Lyme and Babesia, and it's hitting them very, very well. My clinical experience is that it does hit Bartonella,
Okay.
but I can't say if it's hitting it anywhere near as well as it's hitting both the Lyme and Babesia.
Okay.
But we need to be aware that it's hitting Bartonella, because if they're on anti-Bartonella therapy, it can increase the Herxheimer reactions.
Okay.
So we're doing a dance. We're doing a dance as we increase the disulfiram, tapering them on other medications, trying to make sure that they're not undertreated as we take away those medications, and not going too fast as we increase the disulfiram. As I mentioned, I only increase the dose every 2 weeks. Usually gives time for a Herxheimer reaction to pass. If it's a severe Herxheimer reaction, we will either stay at that dose or even back up a bit to give it some more time to percolate, so to speak. The next biggest problem we have, though, is drug reactions. The drug reactions are mostly in the form of headaches, fatigue, sleepiness, brain fog, and an assortment of other symptoms, perhaps muscle aches or myalgias. And it took a while to discern that in fact is a drug reaction, and doesn't fit into one of the other categories.
Right, that's hard for us, yeah.
Right, but it became clear when some patients would miss their drug for a day and say, I can't believe how good I feel.
That's how I've discovered it,
Yes.
too.
And that's how we're able to pinpoint, oh, okay, now we know. Now we know those symptoms that went away when you missed your drug for a day, those are drug reactions. And then we do our best to try to mitigate those symptoms as people continue to progress the dose. And then we come to the question of what's the treatment dose, or I should say, what's the maintenance treatment dose?
After 60 to 90 days?
No, after progressing the dose.
Okay.
What dose do we reach? What's the maintenance dose? And how long do we keep people on the maintenance dose?
That's what I'm hearing. So are you implying Dr. Liegner's study said 60 to 90 days at the core dose? Are you saying maintenance dose tells me you want to keep people maybe on the disulfiram longer?
So this is a question of nomenclature. What he's calling core dose, I'm calling a maintenance dose.
Okay, thank you.
We're talking about the same thing.
Okay.
Yeah. And Dr. Liegner's had more experience than I have in terms of the number of people who've gone through the entire prescription of disulfiram.
Okay.
So at this point, I'm using Dr. Liegner's guidelines. He's keeping people on 6 to 12 weeks, more or less, of their core dose, or what I'm calling maintenance dose.
Okay, thank you.
And Dr. Liegner has suggested that core dose be based on weight.
Right.
That is the only criteria we have at this point. It's very clear that people with detoxification issues, methylation pathway issues in particular, are going to have more trouble tolerating any of the doses, and we do our best to modify those pathways. But I can say at this point that this is a game changer. This really is a game changer. We're used to having patients on long-term medications, both prescription and herbal antimicrobials, as well as dealing with their mold toxins, their food sensitivities, all the chronic gut issues, the endocrinopathies, the adrenal insufficiency, the thyroid problems, the problems with the other glands, particularly pituitary gland issues we see, particularly with the mycotoxin group, but all of these are affecting the patient's well-being. All of them are affecting the immune system, the nervous system, the endocrine system, as if they're different systems. Of course, they're not.
Right.
We are all one big system.
Right.
And anything that hits one aspect is going to hit the whole. So we're doing our best to keep people in balance. We're not just giving them antimicrobials.
Right.
Something that's changed to some extent because the disulfiram has been so effective, though, is I'm actually introducing it earlier in my more fragile patients than I was introducing the other antimicrobials. So instead of putting people on Rocephin, for example, an intravenous medication, or giving them amoxicillin, et cetera, in those patients I was saying, okay, you got to make sure that your adrenal, your thyroid, all your food sensitivities are figured out before we start this, but we're getting so much benefit even at lower doses of disulfiram. While I'm working on those issues, I'll start the disulfiram even a little bit sooner. As we know that these infections are causing systemic inflammation, making all those problems worse.
Right.
And it's a little bit of a jigsaw puzzle. What do we do first? What do we do second? How do we keep this patient stable as we can, and better and well balanced, and not disrupting, not making them worse in the process. First, do no harm.
Such great information.
Mm-hmm.
Yes. You mentioned a big key for me. I am a Lyme patient. I am on disulfiram. I have 4 kids at home as well with Lyme. So there's a lot of people like me who are very interested in this drug and how it has changed the face of Lyme. But you hit on something very important. What do you do for a patient? Say, take your fragile patient that does have gene mutations and their detox pathways are just, plugged up. What would you do?
In those patients, I will work very hard on those detox issues before I'll start the disulfiram.
Okay.
And so we're checking out the methylation pathway. We're also putting them on binders, which not only will remove toxins, neurotoxins specifically, but will actually remove cytokines and decrease inflammation. We do everything we can to just lower the inflammation in the body through various interventions. So that includes working on diet, giving them curcumin, etc., to just try to decrease inflammation. Any of the things we can do in that respect are going to help stabilize the patient. And again, it comes to how fragile they are before we're willing to give them an antimicrobial, which could destabilize them for a while. Also, we're starting people on very low doses in that particular case, while the average patient who's already sick, we're not talking an average normal person, we're talking an average patient who's been sick for years.
Right.
Somewhere between 62.5 and 125. Some patients are starting on 31.25.
Daily or every third day?
Thank you. Every third day, every fourth day, every week. I have 2 patients. We've gone to a compounding pharmacy and given them 25 milligram capsules, and they're starting on 25 once a week to see how that's working. The good news is I have not had to stop disulfiram in any of those patients.
Oh, that's amazing. All 60? Or just...
In any of those fragile patients who herxed a lot. There is one patient who I've stopped disulfiram, and that was because her liver function enzymes had gone into over 300.
Oh boy.
And I wish we could have given her more liver support nutrients, etc., and it wasn't working with that patient for a couple different reasons. And even though we backed off the dose, because her enzymes were elevated to that extent, we did stop it. As you're aware, there are a handful of serious reactions from disulfiram. That's the most serious I've seen. The rest are well cataloged.
Okay. Wonderful. So that's a pretty small percentage, it sounds like, for severe reactions. Do you have any other patients that have had rare side effects or anything like that outside of that one patient? There's so much. My idea here is to help get good information out there so patients aren't terrified to try this drug or at least discuss it with their physician. Do you have, what is your clinical experience with introducing this idea to someone who has heard those terrifying, other people who have herxed their brains out, so to speak? What do you say to them to get them to consider the drug as an effective therapy?
That's an interesting question, because most of my patients said, let's go.
Right, I was eager beaver too.
Right.
Yeah.
But I simply make it clear, there's a handful of potential serious reactions that are very rare, that we're going to start at a very low dose.
Right.
to see how they tolerate it. I'm not worried about any of those problems at those doses.
Right.
And I don't have problems convincing my patients because we're doing it in such a benign way. You know, I do think it's problematic, people starting on 500 milligrams a day or even 250 milligrams a day.
For sensitive people, that's high.
That's very high. The vast majority of my patients would not tolerate those doses. And I feel very comfortable. Thankfully, my patients feel comfortable with me and they trust me. And when I say, you know, I really don't expect any problems at these low doses, except for perhaps a Herx reaction. They know what a Herx reaction is, and we know how to deal with it. Worst comes to worst, we'll stop the drug.
Right.
But I haven't had to do that yet.
Okay, that's wonderful to hear. There's just a lot of misinformation out there about this drug, and that's why I wanted to do these interviews and come to the conference and hear Dr. Rajada speak on it. So in 68 years of studies using this drug, the reports have been adverse liver function, neuropathy, and psychosis. And
some optic neuritis has occurred. Yeah, there's a handful that, again, they're rare.
They're rare. That's what I want to hit on.
Yeah, these really are rare. Like I said, I have one patient with significant elevation in her liver function test out of those 60 plus. And I do have my patients get periodic blood testing for that reason only. I'm not really worried about those as long as we're going slowly and people are forewarned.
Right.
I would say that compared to other drugs, the risk profile is actually quite low.
Very low.
Yeah. I mean, every drug, when we look up side effects,
Toxic.
there's a long list. This is a relatively short list, and a relatively short list of interactions with other drugs.
That's wonderful. Two things, because I know you don't have all day to spend with me. Bartonella is quite an issue. You say that you think that it does hit Bartonella a little bit. We don't know exactly until the studies come out. But what would you say? There's so many patients. I admin a few of the Disulfiram for Lyme pages, and we see a lot of people that are struggling with Bartonella. And our experience as patients have been, with my physician, get rid of the Lyme and treat Babesia, and Bartonella tends to be easier to get to. What is that? Would you agree with that?
I absolutely agree with that.
Okay.
And initially we'd look at patients and say, oh, well, Bartonella seems to be your biggest problem. Let's go after that.
I know that's what you think, but it's the opposite.
It's not a good idea. I do the same thing your practitioner does. I treat the Lyme first in most patients. That typically is the easiest to treat, not the big problem that one hears in the media.
Right.
I treat Babesia as well. Bartonella, I really think, is the most difficult to treat.
Yeah,
even,
for sure.
Even the infectious disease people say, well, we use triple antibiotics and we don't think we really get rid of it. What they don't see, appreciate, or at least write up on is the Herxheimer reactions associated with Bartonella. It causes a long list of autoimmune problems, serious inflammation, and particularly neuroinflammation. People with the most serious problems associated with neuroinflammation that limit their lives because of particularly the neuropsychiatric aspects as well as the neuropathies and so on, the cognitive dysfunction, headaches, and it goes on and on. Usually Bartonella is there, and often with help from Babesia and so on. But Bartonella has been the hardest to treat. What I've experienced with Disulfiram is that we are getting Bartonella herxes. It does appear to be hitting Bartonella.
That's wonderful news.
It's wonderful news, but thus far, which in our clinical experience, which is early, it's not hitting it as well as it hits Lyme and Babesia.
Right.
Lyme and Babesia, we even venture forth with the word eradicate. I have not used that word. I have not used that word with my patients. I say, we're not talking about cure, we're talking about remission, and hopefully to a place where your own immune system, perhaps with some help, can keep this bug at bay, along with the trillions of other bugs that we live with, that we
Right.
cohabitate with. And we see that happen, but we also know, or we also experience that these bugs are still there, and if someone gets hit in the head or has other traumas, gets put on corticosteroids, or a lot of stress, a vaccine, I mean, there are a lot of things that can suddenly precipitate a relapse. So far, given Dr. Liegner's experience, where he has seen sustained remissions, taking people off of disulfiram after for years they were being treated with either consecutive antibiotics or recurrent antibiotics, including intravenous antibiotics. And now, over 2 years with this first patient, they're good.
It's
They're
remarkable.
really good. Yeah, this is
remarkable.
It's a game changer. It's very exciting, very exciting. Yeah.
So what do you treat with for Bartonella?
So, if we're treating Bartonella aside from disulfiram,
Well, I'm more interested in with disulfiram because we hear you saying you treat Lyme and Babesia with disulfiram first, and then do you bring in rifampin or?
so, remember that a lot of these patients are already on antimicrobials. So if you're talking about a new patient,
Okay, let's say that then.
a new patient, I would start on disulfiram first
Okay.
and monitor them carefully in terms of symptoms and how we're progressing the disulfiram. I'm presuming that I'm hitting the Bartonella to some degree. I'm going to hold off adding rifampin, adding Bactrim, which is
Been on it.
sulfamethoxazole, trimethoprim, or any other anti-Bartonella drug or herb. I'm going to hold off doing that until we've seen how much benefit we can get from the disulfiram, and then add in some agent that's going to go after the Bartonella.
Simultaneously, depending.
I would say that it's going to be very individualized.
Yeah.
I don't ever change two things at the same time.
Okay. Yeah.
So I want to know exactly what the disulfiram is doing and at what dose. And if we're making progress, then I will continue with the disulfiram, have them go through the entire disulfiram protocol, and but when they're stable on whatever that core dose or maintenance dose is, and I'm seeing Bartonella symptoms poking through, I will add an anti-Bartonella agent.
That's wonderful. The other main important thing I think most of us deal with is Candida.
Mm-hmm.
I heard you talk about it. It's very interesting to hear your take on how do you handle Candida. I thought that disulfiram had got to Candida, so I stayed away from fluconazole and nystatin, but boy did I get a rearing case of Candida on disulfiram, which surprised me, but I also was eating some candy at the time. I don't normally do sugar, so my body was telling me, no, let's stay away from it. But what do you think on Candida on disulfiram? What's your take with your patient group?
If a patient has clear-cut Candida issues before we start, many of them do, I will treat their Candida aggressively with diet and anti-yeast agents and probiotics, etc. We know that Candida can be metabolized to acetaldehyde,
Right.
and we want to limit acetaldehyde production. And I will continue to keep people on low yeast diets, low sugar for sure,
Yes.
no alcohol obviously,
Right.
and I have kept people on anti-Candida agents while they're on disulfiram.
Okay, that's very helpful. Yeah. Okay, so detox-wise, what do you think about sauna use while on disulfiram? I've had experience with myself and others helping patients get through Lyme treatment, but disulfiram is quite a different animal because it's so broad spectrum, and the herxes can be so insane. I have stopped my sauna uses just because I felt like I had one that caused so much die-off that I thought, okay, I'm a stickler for just doing disulfiram. I don't do binders or anything while I'm on it, just so I know what disulfiram is doing and what it's not doing. But the sauna use seemed to increase die-off to a degree that led to some neurocognitive issues.
So
what is your take?
My first question is, how often were you doing saunas?
Well, I was adding ozone to the picture, and that's quite a strong oxidative therapy. So sauna use I was doing when I first started disulfiram 3 days a week, but with ozone. So my sauna use, I used to just use far infrared, but then I learned about ozone, and I really became a big fan because I felt pretty darn good, and I wasn't having to do much, just ozone. Also did insufflations as well, 3 to 5 days a week regularly, and then I would take 10 days off. So on disulfiram though, 2 days a week, and then I went to nothing because I want to see how to adjust addressing detox on disulfiram just with disulfiram and then go from there. I don't want to increase the die-off because disulfiram is it's quite a warrior on my side, so I don't feel like I want to interfere with the work that it's doing. Do you have patients that you have seen use saunas that can cause more die-off? Do you stray them away from that as a detox method?
So I think it's important to make a distinction between saunas and saunas with ozone and other ozone therapies.
That's right.
So if we're just talking about saunas,
okay.
In general, I don't think we're talking about die-off problems. I think we're talking about mobilizing toxins.
Okay.
And because we can mobilize these toxins fast, particularly with the far infrared, faster than our bodies can excrete the toxins, whether it's via the kidneys or via the bowels, lymphatic, sweat, etc., that we will have an inflammatory reaction because of the increased circulation of toxins. It will feel like a Herxheimer reaction. It is a systemic inflammatory reaction, but it's really just a toxicity reaction.
Okay.
That's one issue. Another issue is, as we talked about earlier, I won't do 2 interventions at once. If they're ramping up on disulfiram, I'm not going to add something like saunas.
Or ozone.
Yeah. The ozone, of course, will also, can also cause.
It's very strong.
Herx reactions for sure.
Yeah.
So I'm really not going to do those unless a patient has been stable on them already.
Right.
But just the way we taper off the antimicrobial agents, I might taper off the ozone at the same time, because if we're hitting the bugs from too many directions, we will be getting more herxes. One thought that it came to me though is if we raise core body temperature to 102 degrees, we don't kill the bugs, but we do improve the efficacy of the antibiotics. And it's possible that the saunas could precipitate a Herx reaction simply by making the disulfiram or any other agent more effective.
More effective.
Yeah, that's possible.
That's interesting. I never thought about that.
So there is literature to that effect. Not looking obviously at disulfiram or ozone, but other antibiotics. The main point I see is always staggering interventions so that we know what's doing what, and then we can modify the plan accordingly.
That's very smart. I like the conservative approach that you're taking. I had led by Dr. Legner's dosing per weight as well. And when he was saying 125 every 3 days, I heard 62.5 because I'm so conservative. I have 4 kiddos at home that I carpool everywhere across Texas, so I need to be available and out of bed and available to drive.
I hear you.
So I'm going as slowly as possible.
Mm-hmm.
What do you say to those patients that I see on my Facebook pages who are so desperate to get better? And my heart just pours out to these people because I feel for them. I've been there. I know you've seen it in your office way too much. But they're wanting to go so hard so fast. What do you say to them? It's so hard to convince anybody to go low and slow is my motto. But what do you say to those people that just go gusto for 500 to get it over with? Because they're so desperate, and I understand, but
yeah, I mean,
it's a concern.
Sure. My feeling, of course, is I want to slap them across the face and say, wake up. But I don't do that.
I love it.
And
yeah.
what I explain to them, though, is, this is not a John Wayne, watch how hard I can do this, and then I'll get on the other side.
I think
it doesn't work. It doesn't work.
No.
And I tell them, this is not a sprint. It's a marathon. And the tortoise will beat the hare. And you not only, if you try to go too fast, will you get really sick, but it'll set you backwards. I mean, it's more systemic inflammation. It's more interruption of what normally should be happening in your body. And it can make you worse, not just temporarily, but for quite a while, and make you much harder to treat. I explained
that's interesting.
And I explained also, I said it's like pissing off the bugs. Not literally, of course, but that's what it feels like. Like they come back with a vengeance when they do it. And patients who go that route, they don't tolerate doses that they previously tolerated.
Oh, okay.
Yeah. And
do you think it's because the inflammation is?
I think they become more sensitized. If I had to speculate in terms of mechanism, I think that because the body's been more sensitized to various aspects of the microbe that have been attacked by the antibiotic, that now even smaller doses of those microbial elements are causing systemic inflammation than previously. That's just speculation. But clinically, that's what happens in a lot of patients. I can't say, oh, you were on 10 drops of Cemento and you decided to go right up to 15 and it was a real mistake. But they generally won't tolerate 10 drops anymore.
Wow, that's really interesting.
They have to go to scratch, and maybe they won't tolerate Cemento at all. So I do my best to talk patients out of that.
Yeah.
Most of them have been sick so long that it's not hard to convince them. The ones who haven't been sick as long and think, I can do this, I'm just going to push right through, they suffer for it. And I do my best to try to convince them not to do that, and they learn the hard way. It's sad.
It is very sad. The thing that I'm seeing is there's such little clinical experience in these doctors that are out there that us patients are doing such a great job to convince to prescribe this for us. Mm-hmm. I just wonder if this difficulty isn't because the lack of education and God love these physicians for trying to help their patients. I'm not pointing blame at anyone, but I just wonder if there's a lack of guidance here and maybe they've used alldaychemist.com and don't have a physician that's helping them. We definitely steer them, obviously, to not go that route because we want them to be accountable to someone who cares about them and who's going to follow them and help them along, start slow. I'm seeing a lot of moms in particular who, some are single parents raising kids by themselves. And I pause because this is such a near and dear issue to my heart that I feel for them. They want to get better faster and they think that this is the right route to go. And of course, I'm just a patient. I don't want to tell them this is what to do, and I never make advice. But for that person that has to work, you're saying the go low and slow is definitely the tortoise approach, beating the hare.
There's no question. There's really no question. And I do know of doctors who, for example, are starting people on disulfiram at 125 milligrams a day and increasing it weekly. the feedback I've heard is that half the patients are dropping out.
It's too much.
It's way too much. My patients will not tolerate that. But there are a whole lot of other considerations. We've talked about the comorbid issues and so on. Because of all of that, as you may or may not know, I've been practicing medicine for over 40 years. I'm board in internal medicine, but my practice initially was what is now referred to as integrative medicine.
I love that.
Back then it
So
was
glad.
holistic medicine, but I also developed an expertise in environmental medicine.
Oh, nice.
And all of these elements are important for our patients with Lyme disease complex.
It definitely is.
And you know, the famous physician William Osler said, if you know syphilis, you know medicine, because syphilis attacked every organ in the body, and you had to understand how the entire body works to understand syphilis. Well, it turns out that Lyme is a cousin of syphilis. It's
Right.
also a spirochete, but it's also immensely more complex.
That's right.
Immensely more complex. One practitioner referred to syphilis as Lyme's dumb cousin. So, you know, people have really, really complicated illness. And it takes some detective work and sleuthing to figure what all those components are, and then experience in terms of when to intervene, where, and with what. And it was for that reason that I wrote a book, and the book's going to come out next year.
Oh, I'm excited to read that.
Yeah, so the title of the book is Recovery from Lyme. The subtitle is The Integrative Medicine Guide to Diagnosing and Treating Tick-Borne Illness. And it's going to be almost 500 pages long because,
Wow.
as we've talked about, it's really complicated. It's really complicated.
It is very complicated.
And of course, I discussed Disulfiram.
Oh, you
By the
do?
time
That's wonderful
By the
to
time
hear.
the book comes out, we'll have a lot more clinical information. And
Great.
right. But excuse me. But it's very exciting. We really are making progress. You know, despite the fact that most of my patients have been sick for years and some decades, really.
32 here.
There you go. 90% of them get better. 90% of them get 80 to 100% better.
On Disulfiram.
Before Disulfiram.
Okay.
Disulfiram, we have something new which will help even more people get even more better. I'm convinced of that at this point. And we're on this learning curve, and we will continue to find out lots.